Okay, welcome. Thanks so much for coming. If we could start coming in and closing the doors, people can keep trickling in. And there are some online people waiting for this talk, so we're going to get started. Thank you so much for coming. My name is Alexis Rickard. I am the Vice President of Individualizing for 2 more weeks. And we are really excited to have Dr. Nichols here, and because so many of our medical experiences have included this myopic view of one body part of our loved one, and this is such a refreshing approach, and I'm excited for you to hear. And I know Dr. Nichols' face is on a stick there. Robert Couch, don't be fooled if you see a face Reid walking around. But please welcome Dr. Nichols.
Here. So pretty funny. Last summer, I was actually going to follow that face of Robert, who was carrying it around Michigan, because I just came from Michigan this morning, and I was going to go to his house and actually surprise him, because it was about an hour out of my way, and I was going to show up and say, "Hello, here I am." But he got COVID, so I couldn't go. So anyway, I'm so thankful to be here, and I'm so thankful to see all of my friends that are at this meeting. There's nothing more welcoming than to walk into a place when you feel so at home, and especially when I see cute little faces that I get to smile at and wave to me. So I'm Reid Nichols, and I come from Wilmington, Delaware, at Nemours Children's Health. It changes its name about every 5 to 10 years, and so just stay with me here. We do not have borderline personality problems. We do actually love AMC, and that part has never changed. I have some disclosures, but they are not related to this. All the participants in my slides have given permission to have their pictures here. So I really like to think about arthrogryposis as treating the whole patient. And we can definitely break it down, and I think it's really important to talk about each body part, but the whole patient, the family, that's really where I feel like we have to come from. And so I want to talk a little bit about what makes a multidisciplinary team, what things are we thinking about when we're creating the goals of our treatments, and then what does the future hold? Do we have any ideas for that? So my motto is definitely, alone we can do so little, together we can do so much. And I really look to my friends in physical therapy, and you'll see how big my team is, and my friends who have arthrogryposis, which I do not. So I think it's important to be able to push each other along. And this was Misha at our Brace for the Race with Mike and Rini alongside of her, and this was one of the best days I think I've ever had, was at this 5K with a Ninja Warrior course. So it's October 21st if anyone's interested in coming. So at Nemours, this idea of a multidisciplinary team started a long time ago, 1986, actually before I graduated high school, I can at least say that, by these two amazing men. And I think we've really grown this idea, and we're not the only place that does this, and I think that's really important. So what does the team have to consist of? Well, the number one person in that team is you. It is the patient and the family, and it's how we interact with all of these individuals that make up my team. And I'm going to tell you, I could go on forever, because arthrogryposis involves so many different parts of us. It involves gait lab and prosthetics and making sure we talk about our cast techs and I like to joke, we call them my work wives. I have a really amazing team at Nemours, and we all communicate, and that communication between us makes us smarter. And remember, who is the center of this universe? It is you guys. It is the patient. It is Sarah sitting right here. And we have to figure out what common goals we all share. And I didn't include plastic surgery and OMT and all these other people that actually are really important in this group. So why do you need a multidisciplinary team? Well, because there are a lot of issues that are involved in arthrogryposis. And it certainly is not a one-stop shop, because a lot of people have different involvement. And so we have to know how to take care of this, making sure that you have a captain of your ship that knows who to reach out to and how to contact them very quickly. So how do you prepare to meet the team? Well, number one is you want to maximize all the information that you get from us. So you want to come prepared. You want to come with your questions. You want to make sure that if you've had treatment in multiple different places, and I would encourage you to have lots of different conversations with friends that are also, that are at this meeting. There are tons of us that are maybe have a little different perspective, or maybe you just needed to say, it a little differently to somebody, and they'll give you a new great idea. Make sure that you bring those medical records with you, because although our electronic medical records are okay, it doesn't always relay the message. Maybe you need to summarize it so that we get right to the point. Bring those radiographic studies so we can upload them on our individual obnoxious PAC system. Bring surgical reports. Bring your braces. Maybe you had a brace 3 times ago that worked really great, and the one that you have now just is not cutting it. And then, as I said to begin with, bring your list of questions. So the way that we approach this is we have you guys in one place, and we bring everybody to you for the most part. So we always have a PT, OT, upper extremity, lower extremity person. I have some other subspecialists in my practice that I like to have a second set of eyes. So I have a hip specialist and spine specialist that I also bring in a lot of times. The most important thing is that we try to promote communication within the team members. So that, to me, is super important. We want also for you guys to run out into the hallways and meet people that look just like you, or parents who are dealing with the same exact struggle. Or Gayla's not in here, but she is an amazing tennis player, and I had 2 boys that were struggling, and so I showed them a YouTube video of Gayla, not telling them that she was in the next room, because they were teenagers and just were struggling. And so I brought Gayla into the room, and I said, you know what? This is Gayla. She has actually less mobility than you do, and look what she's doing. You can do this too if you want to. So I think that getting people to meet each other is really important. And the same questions that one parent has maybe figured out, another parent may have just started to ask the same question. So what information is important about your child? Well, I could start talking about all of these things, but the things that I care about is, where are we in school? How are we doing emotionally? How are we doing physically? Can you play on the playground? Do they have friends? Do you have a big vacation coming up? So if I say, hey, we're going to put you in a body cast this week, that is not going to cut it. All right? Are there stressors in your life? Let's say another child is having some issues too, and you really need to put them as number one at that moment. Those are the kinds of things that you need to bring to the table so that we all know what to talk about and how to set goals appropriately. So the bottom line is basically everything is important about your child. And you. I mean, maybe your parents are struggling too. So when we develop this treatment plan, we really need to think about it in a pretty strategic way. We need to communicate between all parts of the team. Even some, I might not talk to urology all the time, but actually I seem to find every urologic problem there is in the middle of the OR. So it's good when your team member can communicate with other people that could be really helpful in your goal setting. What's on your problem list? What should happen first? What events are coming up in your next, in the next few months that really would get in the way of your long-term treatment plan? We want to, as our team, we want to be collecting this data, deciding what is really relevant to our success. But most importantly for me, it's maintaining a very holistic approach. The family as a unit is important. The child mentally and physically is important. So our goal is to bring the whole team together to maximize function and promote independence throughout the lifespan. So Rini always teaches me, the child might be 2 months old. Well, let's just figure out how they're going to drive when they're at college. I'm like, what are you talking about? Why in the world do we care about college at 2 months? Well, we do. We want to know how independent they're going to be, how they need to set up their life to make the best plans to financially support them, FMLA, all of those things, and what needs to happen in what chapter of life. So I will say that Miss Mary, who is here today, she had a lot of surgery, and then I got this text message. Mary has wanted so desperately to jump like the other kids, and today she accomplished her goals. This, to me, is why I do my job. Those kind of text messages that I get, I feel like almost every day, are important. Gabby wanted her leg lengthened. I said, absolutely not. That is the wrong decision. I should not do that. You have arthrogryposis. You're contracted. I should be shortening. And there she is with that huge smile, because at her prom, she strutted her stuff, no shoe lift needed, because she was even. And that was her goal, and she accomplished her mission. So age does matter, too, when you treat AMC. In the newborn, we may be thinking about how can we use those stretchiness of their tissues, what kind of other medical problems do they have, making sure that I teach you the simple things about good hip positioning, how much you can do, how much just touching a baby's foot or knee or hand or shoulder can make that child really respond with the soft tissue softening, and it makes my job easier, and that is important to me, to always look like I'm doing a better job than perhaps I am. We do a lot of casting in our clinic, but I also do a lot of early intervention now with little tenotomies and very small releases that hopefully will get us over the end zone a little faster. So as they grow older, I'm still thinking, doing a lot of casting. I always say, behold the power of a cast. But I also have to know that this is a child who also needs to achieve their own gross motor development and fine motor development, and the family needs to be able to touch and nurture that child. So there is, we have to find a balance. We talk about the hips. Should we address them early? What are the anesthesia risks that we have to consider? So all of these things are in our minds as we're going through this. The toddler, we really want them to be able to function and play. Looking at the upper extremities at this time is not a bad idea. I look at Ryder in awe because he was 18 months in this video, and I'm telling you, my 18-month-old, no way in the world was going to be riding a scooter like this. So as they grow older, we also need to time our surgical interventions to meet the family's needs and to meet the functional needs of the child. We need to consider all those other things, not just, oh, I see a knee that's bent, it needs to be straightened, or a knee that's straight needs to be bent. Each growth spurt is a time to reconsider our brace. Maybe there's something we haven't thought about. We want to, again, even as a child, we want to think about how are they going to be able to drive, and then to know that these children grow fast and furiously. It is not a failure if you have to recast or reconsider your plan because it's not working. Good. Sorry. And as they grow older, you really have to figure out what their alignment is, how they're going to go off to adulthood. I just got approached with Dr. Vivasa by 3 who are older teenagers, and they are considering what is next for them. And I can't provide necessarily care because I work in a children's hospital. That is terrifying to me. I would take all comers if I could, but we have limits, and that's really frustrating. But there are some places like the Paley Institute, you can go there as an adult, and that's a great option to know. But you can't take care of every single adult arthropodic child, or you will not have time for all of the others. So we have to figure out how we make that transition. So, some of these children feel really good. She's riding her horse here, and she feels amazing. Well, we finally realigned her, and now she's even better at riding. And she has, I think, a little bit more independence. Her brace wear is easier when you don't have necessarily the most experienced orthotist, and maybe you live in a very small area and you don't have somebody that can accommodate a lot of deformity. Well, it's really nice to have straight alignment because it makes it much easier for them. I want to make sure that you all know that Nate did not score that goal in me, just FYI. Okay? And as you grow into late teenage years and adulthood, as we talk about this holistic approach, I think that it's important that we pain is definitely, we've seen in our research that is a problem, and so you want to make sure that we maintain, for all of us adults in the room too, it's the same thing. It doesn't matter if you have arthritis or not. Are you taking care of yourself? Are you taking vitamin D? Are you eating well? Maybe you have a gluten issue. Maybe that causes inflammatory processes in your body, and you need to cut that out because it's hurting you. So think about that. Extra weight doesn't help any of us, unfortunately, and trying to keep everybody in my practice, I want to keep them healthy, active, engaged, and mentally and physically as good as they can get. The goals of treatment, the basics build the future. We want to eat, sit, and stand. She just got her driver's license. That was a big deal. So now she's graduating from college, and I'm super excited. But she, has accomplished a lot to get to that mission. So I think pretty much we all know about these typical orthopedic involvements in arthritis. I'm not going to spend a lot of time. The one thing that I know that I personally, because I look at the lower extremities much more fondly than the upper extremities, I also have to think every time I see a patient, how's their spine doing? How are their hips doing? How are their hands doing? Are they functioning well? Is there anything I'm missing? So to go through a checklist, I think for providers is really important because really everything can be involved, or maybe just the hands and the feet, maybe just the feet, who knows? But to make sure that you go through that checklist is really important. And for me, I constantly have to remind myself not to forget that spine. Hips, I think there's another session on hips, but if there's one out and one in, I almost always will tell you I would like to put that out one in. I think that gives balance and helps keep the spine healthy. I'm also not opposed to putting both hips in because I think they like to live in their socket, but you do run the risk of stiffness. So you kind of have to talk to your provider. I think knee deformities and arthritis is very interesting to me that I think we're all pretty aggressive with the knees now. You can't predict necessarily who's going to maintain amazing function and who may lose some of that just based on how their tissues respond to surgery. But we do a lot of shortening, a lot of tissue releases, but and getting quick motion is important. The only problem is maintaining that same range of motion is sometimes challenging, but really good physical therapy is super helpful, and doing the surgery at the right time for the right patient. Foot deformities run the gamut of turned in or turned out, so clubfoot and congenital vertical talus are very common, and it's obviously very common to have foot involvement with these patients, up to 78 to 95%. I still do a lot of casting for these with a very small soft tissue intervention. I don't like to do huge things if I can avoid it because I think a lot of these scars heal with arthritis scarring, so that's not always super helpful. So how do we reach our goal? Well, I think it's with passion and with persistence, and a little hope in there isn't so bad. So we want to maximize function, promote independence. Some therapists that you meet, not the ones that I see sitting here in the room, never lose hope. And I think that there are some times when a therapist that may not have taken care of someone with arthritis may say, well, I can't make you better. And that's actually not what your goal is. Your goal is to promote function and independence. So there are a lot of tricks of the trade, and I think there are a lot of ways to educate, and we try to keep a very open line of communication among the outside therapists, and I know Fran is here, and I think that she does an amazing job with that too. So there are many ways to do this. You can cast, you can brace, you can do surgery. We do a lot of gait analysis, so I don't know what, sorry, I wasn't advancing. Arthritis, number one, is not a one-size-fits-all diagnosis. So therapy may work for some or for sometimes. It can be a different treatment plan for two different kids. Obviously, children grow quickly. We have to utilize that growth. We have to maximize our ability to intervene at the right time for that. And surgery can improve function, but it does not cure arthritis. I believe pretty strongly in that. So we want to predict the future. We want to help you figure out who, parents want to know, will their child walk? How will they walk? And, I believe pretty strongly in the power of positive thought, so I can't be the one to tell you you'll never walk. But I do love disproving other people who've said the same darn thing. So foot deformities, you may look at something like this and say, no way, no how, never going to straighten out. And that I think we learned a long time ago to stop saying. Because there's amazing things that you can do with simple casting, simple tiny surgeries, and you can get amazing results. So this is one of my favorites just because, boy, when Mary walked into my office, I said, no way, no how, and Reid told me to stuff it, and so then I kept moving on, and really we did a total of 4 casts on her. Now, not to say that you don't have to come back and do a little something, but that's how she walked into my office, and then this is how she was after those casts. And to me, that's a home run, and her hip is dislocated in this one. These slides are moving slow, sorry. But that was 6 months after surgery, and I have to tell you, I would try to demonstrate my inability to do that motion right there, but I can pretty much assure you can just believe me, I can't. So sometimes you have to accept good enough. So when orthopedic surgeons are taught about ANC, we are taught to, you just need a braceable foot. So, you kind of get things as good as they can. In some cases, perfection, even though I believe Dr. Van Bossen and I would argue together that we would like perfection, and absolutely everything. We want it to be as typical looking, we want it to be easy, no braces, no nothing. Well, you can't always get that. So, like I said, there's a time and a place for everything. So right now, come on. I also can't do this. I'm not going to demonstrate this one either. But her feet were not great in this picture. And that was okay because we would just cast and she would get to this place and she could dance. And then there was a time she really couldn't dance. Just really, it was hurting her. We couldn't get braces to be comfortable. So we did some minor surgeries trying to improve. And then, we just couldn't get there. So I have to prepare for the next part of the journey, both in the education of the family, the preparation for a child who might not understand what we're doing and if it's the right thing. We get a lot of imaging, or I do. I want to be as prepared as I can, and you don't have to be an orthopedic surgeon, but these feet look pretty bad. So, I even got 3D models, we really bring out all stuff sometimes. We do look at gait labs to make sure that we can see, I want to see the before and after. There's sometimes we can pick up some rotational deformities in that gait lab, how they're walking, what could help them get better. And it's kind of nice because, again, it's sort of a multidisciplinary approach. We have multiple people looking at these gait labs together. So we can look at and take some outcome measurements to make sure that we really like how things are going. So we do pediobarographs that shows how they're walking. That red spot is not happy. We look at gait labs and make cool pictures for effect. Here we go, swinging your arms. Not very receptive to my fingers. So in preparation for that journey, the parents, hey, but I started late, that's not fair. So we really need to look, I think I have to encourage the families to go through their checklist, FMLA, how's your job going to support you if you have to come to see me every week or every 2 weeks. What does your insurance allow for PT? If it's 30 sessions, that is the wrong plan for you, because we will be fighting, and sometimes they say, sorry about your luck, we're not doing it. So how are we going to get through, let's say we put an external fixed arm. How are we going to get through that? Do we need Child Life? Are they super iPad fans and they're going to be fine? Are you going to stay near the hospital if you've moved away? So in this case, we went with the gusto. We put on these 2 horrible frames, and we went from a really tough-looking foot through the journey. This is weekly. This is a child that got better with time, but really was done with this treatment at the end, for sure. And, we have 2 frames working, one on the foot, one maintaining the ankle or helping with the ankle position. So a breakthrough is a moment in time when the impossible becomes possible. So we get her straight. She gets credit. She was on that journey that required her to be fierce, and she definitely was up for the task. At the end of this chapter, I got a video of her walking in the creek with no braces, and that is the kind of picture and video that I like to receive. And ironically, she was the one who got up out of the cast. As soon as I let her go, she was ready to walk in her walker, which was, I really didn't think that was going to happen. So, we see a lot of gait patterns in arthrogryposis. Sometimes they respond to casting, sometimes they just don't get there. But unfortunately, I thought I could just whiz these feet around with cast, but it took a little bit more than that. But she's still doing fine. She hardly comes to see me, which is infuriating because I'm like, I want to see how great you're doing. But she's making improvements. So sometimes arthrogryposis, it hits every joint in the body. And this is another really, really special friend. He had never touched his feet on the ground. I think the OTs and the PTs in the room get the credit for always making sure things stay fun, despite what we're starting with. Really not much motion, pretty severe deformities all over. And again, you can't always go for perfection. You have to go for function. And if you get pretty darn good or almost perfect in the eyes of the family, then I think that it is a win. So remember, you have to have goal setting. You may not get, from those contractures, you may not get 100% straight and 100% bent that you get maybe in the operating room. It may go away a little bit when you come out. But you need to keep communicating with your family, communicating with as much as you can get the kid to communicate with you, and you keep coming together until you find that plan that works for both you and the family and the patient. All right? The success is never owned, it's rented, and rent is due every day. So that means that after surgery, although this is the first moment he has ever put his feet on the ground, and he's looking at his dad saying, "Where are your tears? Where are your tears? Why aren't you crying because I am now walking?" Which is funny. I don't think that next video, but he's dancing at one of the children's museums here. So I'm sorry oh yeah, there he goes. Got a little butt jiggle. I like that. So if Misha was in the room, see, it's not just you that can dance. So, we really need to figure out, so this next patient was a much sicker child who had a lot going on, but could not sit comfortably in a wheelchair. And so his goals may have been different than the previous patient, because we really are trying, again, form and function. We want to make sure that we match the goals of the family. This kid that I'm presenting right now, he's not going to get up and walk. It's just not going to happen. He didn't have the mental capacity to do that. And so we were just trying to get him the improved ability to stand in a stander and sit in his wheelchair. So we got him where he needed to be, but there's, you have to be able to pull from your toolbox. There are a lot of different surgeries that you can do, and I think that if you're not careful, you can do too many. And I waited a long time to do any surgeries, but he got pretty nice motion at the end, and I think that was important for him for sitting. So the multidisciplinary approach, putting it all together, it is you and us, and we all have different lists that we need to fill out. We really need to remember what our goals are. We need to work together. We need to remember that each person's perspective, whether I'm the doctor or not, your perspective as the parent matters. And the perspective of the children as they grow to be adults matters. So with the child that was riding her horse, that I am never having surgery no matter what you tell me. Ooh, I'm 18 now. You've been talking about that surgery for the last few years. Maybe we should look at it. And now she's in her new braces. She has a flat foot. Her knees are straight. She can bend them and straighten them, and she's super happy, and she can function more independently. That was a win for her. So my job is to gather the data, try to read the room, try to see what you guys want, what you need, and hopefully we can come up with the same game plan together. I want to bring up a little bit of genetics because I think this is, hello. To me, all the surgery, I'm going to sort of segue here, all my surgery probably means something, better alignment, but I don't think it's the end game. I think that we have to look further. I think there are a lot more discoveries that we do. We want to know if we can, we've got a lot of genes identified, but we don't have them all. I mean, myeloplegia, how come we don't have a gene for that? That doesn't make any sense to me. We got to figure out why contractures happen, how could we fix them? Is there something that we can inject? Is there some kind of modification that we can make? So we have a part of our team is our geneticists, and so I think that if your insurance is on board with that, I think that is a really important part of this, and I think the more genetic testing we do, the more discoveries we will make, and we're getting a little smarter. Remember that the AMC panel used to be 15 genes, now it's over 150, so that's telling us that even if you had genetic testing at age 2 months, and now you're 15, there's a world, it's a whole different world out there. A whole new library has been opened. This was an interesting case of a 10-year-old diagnosed with AMC. She had some difficulties learning, worsening muscle fatigue. They did a gene panel, and then they did another one, and they found that she actually, with the second testing, they actually found a reason for her AMC, and they were able to, in this one case, and this does not happen much, so this is like the commercial on TV where you lose like 400 pounds with one pill. This is not necessarily what's going to happen, but in this case, we were able to make a diagnosis that there was actually some medication that we could do that would modulate her fatigue. So this is super important, just to give you a little hope that there are things happening. Research is important, so in a rare disease, we need to make sure we get funding. And I really love this. This is one of my patients wrote this book, and I think it's really cool to let people express themselves. And I wanted just to kind of run through a little bit of the research we've been doing. We've looked at a number of things that are related to casting and children. We've seen that it does help to prolong the need for lots of interventions. Because to me, from one of our another study, we looked at kids that have had multiple surgeries, and their outcomes in their gait lab at an older age is pretty much the same. So I think we need to be very careful about how much we intervene. The clubfoot deformity remained, but surgical intervention was delayed, and I think that's important. This was the effectiveness of sterile casting in the treatment. It can reduce the deformity in the short term, but potentially, again, talking about delay of surgery, not necessarily we have to jump in every single time. Foot deformities and gait deviations. We do see a lot of residual deformities, but how much they're impacting is the next question. Falls and associated factors among adolescents and young adults with arthroporosis. We did this study here a few years ago at the arthroporosis meeting, and greater number of lower limb orthopedic surgeries were associated with increased number of falls. So these are important facts. Characterizing pain. I've heard pain as a major complaint in the few hours I've been here, so we really need to look at why people have pain, because we see that this later in life is one of the probably biggest dissatisfiers. Patient reported outcome measurement information systems, the PROMIS scores in pediatric patients with arthroporosis. Interesting fact, most children with arthroporosis do not allow their physical disabilities to interfere with their peer relations. I love knowing that. That is important to me. And then when we had COVID as a major problem, and also even distance between your provider and your home. Doing some tele-rehab is, I think, shown to be a good option. And then the idea that families must also work to reinforce treatments by encouraging exercise at home is important. Is making the exercise and touch a part of your own home game plan. So these are all the studies that we've done recently. This is another book just written by one of my very young patients, The Adventures of Gracie and Rose, the story of becoming proudly different. The future holds a lot. We've just begun. We have a very close relationship. Remember, Delaware is really tiny, so the University of Delaware is literally in our backyard. They have a lot of interest in their biogenetics department, helping us. They do a lot of modification of bikes and fun things and Go Baby Go. And then we've talked about genetics already. I've also am really excited that I've started on this campaign with our biobank, collecting tissues during surgeries. So hopefully, I can't say that's going to help anybody today, but I think that tomorrow is very bright, and I found some people that were really interested in supporting me. So we are right now collecting these tissues, and we'll try to narrow down what we need because testing all of them is going to be cost prohibitive, but it'd be really neat to be able to combine with some of the other very big groups for arthroporosis, and I'm really excited that we have such a biobank that will support me, and I have a small fund that I've developed. So we have a repository for these surgery samples, and we'll have to see where we go with it in looking at this gene discovery and this validation. So the final word, advice from a mom. Trust, and I'm not going to read all of this, but trust in your provider goes farther than medicine sometimes. Look until you find a provider you trust, and then get on board with them, knowing sometimes the loudest voice isn't always the best one. Knowing that your child's doctor cares for your child like their own helps on the tough days when your child has a setback or is headed off for surgery. My advice to you, have a couple of opinions. We all, and I think it's really nice to be at a meeting like this because I think there are a lot of providers here that really care about your child, and one may be closer, you just might feel more comfortable with them. It's a journey, and the journey may change chapters, and that is okay. We all like each other, so it's a good thing, all right? So make sure that you trust in yourself and your judgment, and make sure that you're prepared together for the journey. And then you ask questions along the way. Stay as organized as you can, listen to your child, and listen to what your family's needs are, including the other children in your house. And sorry, Rini, I did get on this car before you did. Okay. So thank you for having me.